For the last presentation of this course, I would invite the chief instructor, Dr. Twinkle, who is going to talk to us about the TORIC calculators.
Thank you, Dr. Tejas. So many new things are coming up in the TORIC calculators, and everybody is hearing about the posterior collinear astigmatism measurement and correction in the TORIC calculations. So many nomograms are available. New terminologies are coming up, centered values and IOL tilt factor. So we are going to little bit understand about the why it's needed and what are the fallacies in the recent TORIC calculators and which are is the coming up, what we really required. So in our regular TORIC calculator, which up till now we were using, was we have a spherical power which was given by optical biometry by using the different variables like XL length, keratometry, anti-chamber depth, white to white, or lens thickness. All these variables has been used. You utilize one formula, whatever the formula you want to use, Barrett or SRKT or whatever, you get the spherical power. And this spherical power used in the TORIC calculator by using the keratometry, and it gives us a cylindrical power in the axis. But there were some inaccuracies. We are not perfect till date. So where we were lacking was a little bit understanding about the SIA, surgical indecisive astigmatism. We were lacking about the effect of the posterior collinear astigmatism understanding, influence of effective lens position on cylindrical power at the corneal plane, position of fovea, optic disc tilt, and the postoperative IOL tilt. We will go detail of each of them. First is SIA. Everybody knows SIA. You for any website, go for the SIA calculations, get your SIA done. But the problem with the SIA was the magnitude. Typically shows the wide variation. Dr. X is operating, he is getting the SIA with the 2.4 millimeters. SIA get 3.32, and somebody else is operating and he is getting 0.20. So the magnitude was also typically shows the wide variation. Orientation was also not consistent. Which axis was giving, that was also not consistent. Mean value is not to be applied for individual, but the median value was less sensitive for the outliers. So many outliers will be there, even though you are calculating hundreds of data for your SIA values. So newer thing which coming up is the centered value, because of the better understanding of the measurements and the theoretical model calculations. So because of this, more and more advancement in the power vector method calculations by the supercomputers, and utilizing the different ray tracing analysis cornea by the optical engineering bioengineering systems, we come to know that rather than putting this angle plot in a single angle plot, you can put in a double angle plot and use the trigonometry application of the vector analysis, and this will give you an average of this vector, and it represented as a mean SIA value that is known as a centered value. So the centered value for the less than 2.2 less than 2.2 millimeter incision, it has to be considered as a 0.1, or if it is your incision is nearly 0.28, it should be 1.2, 0.12. It also has been given very well. So even though if you want to calculate your centered value, you can go to astigmatism double angle plot. The same we are using in the SIA calculations. Put your preoperative data, put your postoperative refraction, and what was the predicted refraction, and you will get your centered value. So it is easy to get it. Now another thing which is important to understand is the PCA, posterior collinear astigmatism. Till 2012, we were lacking of this understanding. Standard keratometric and topographic machines were giving us inaccurate results in assessing the net corneal astigmatism power. So Dr. Douglas Cogg has studied 715 eyes of 434 patients, and he found out there is a strong correlation between the front cornea and the back cornea, even it is a with the rule or against the rule astigmatism. And what he found, that most of the posterior cornea are steep vertical. So they are steep vertically, so posterior cornea act as a negative lens. So when it creates a net plus power along the horizontal plane, so it creates against the rule astigmatism. So your patient has a pre-existing with the rule astigmatism, the net effect will be decrease in the with the rule, and suppose patient has against the rule astigmatism, net effect will be increase the against the rule astigmatism. So now over the period of time, in the next year. For this understanding, Dr. Baylor come with the one nomogram that how to apply these variations, and this nomogram has been widely accepted at that time in 2013-2015 time. Nomogram shows better performance than the what we are doing by the only corneal topography or anterior keratometry, but they are also based on the limitation by the population averages. They have average power contributions. So what to do? What about the meridian? We were not understanding about the meridian part, and meridian has a significant role for understanding of the total corneal power. So suppose your cornea has a Vitti rule of 3 diopter at 70 degree, and you apply the Baylor nomogram, it gives the 2.3 at the 70 degree only. It is not considering the angular power. But when we measure now, because we have machines, we can measure the total corneal power, and it gives the 60 degree. So that was the lacking in the Baylor nomogram. So we need a total corneal astigmatism measurements, and posterior corneal astigmatism change the net power of the corneal astigmatism on the axis on the net astigmatism plane. So nomogram do not address this issue. Algorithms and direct posterior corneal astigmatism measure can do. So in 2016 we come up that you have to measure the total corneal power rather than going to based on the normograms. So the 1 or 2 years it was considering that the total corneal power is very important, and the IOC 700 was introduced and TK value has been introduced. So this was going to be a booming up. So because of these so many machines we can measure the PCA. Now it has been confusion because we have so many nomograms: Baylor nomogram, Avula-Pekko nomogram, Coughlin coefficient. We have so many calculators which are incorporating the total corneal power, or they are assuming the considering the nomograms. So whether we have to estimate the PCA power or whether we have to measure the PCA power, that was a very important thing to consider. And this study, landmark study in 2017, come with this widely used formulas like a Barrett or Abula-Fekko or Panacea and Panoptics. All these TORIC calculators are widely used, and they had compared it. And the comparison gives that the Barrett TORIC calculator and Abula-Fekko formulas gives the lowest astigmatism prediction error, but they were not superior to the estimation. So even though you are measuring it or whether you are estimating on the nomograms, till that those phase, it was not considering as a superior of any one of that. Another important understanding by this one is the devices are different in the total corneal power measurement. You are measuring total corneal power on the SIMFLO. You are measuring total corneal power on the IOL 700. So both has a different total corneal power. So even though there is an intervariable problem with the measurement, total corneal power measurement, so which to apply? So that was also confusion. So at present till time it is considered that the estimation and the nomograms both are working very well. So rather than going for what the market says that you buy for the total corneal tomography, there is no need. We have so many good nomograms and they are still giving the equivalent results, not the superior results are there. Of course, they are good to measure the PCA, but it is not necessary for us to utilize the newer machines just to measure the posterior corneal power to buy it. Particularly, things works very well when you are measuring the posterior corneal, when the outliers are there. So you have a very high oblique astigmatism. In such cases, the chances of the prediction error are very high. In such cases, if you are measuring it and you are applying it, it gives a little bit better results. Going for the third thing, influence of effective position on cylindrical power at the corneal plane. This is mainly important for the understanding of the which TORIC calculator you have to use. Because TORIC calculators are based on the two phenomena. One is the fixed ratio and second is considering the estimation of effectiveness position. What do you mean by fixed ratio? Your IOL power astigmatism has to be an astigmatism at the corneal plane. That has to be considered. The fixed ratio toricity, that means 1:1.45. So 1.45 of the corneal plane correction IOL plane will correct the one diopter corneal plane. So those certain TORIC calculators based on the estimated ELP. Now what is estimated ELP? Because 1:1.45 is okay for the average length, axle length. But when it is a short axle length or when it is a myopic patient, it should not be like that. When high hyperopia, the ratio is changed from 1.2 to 1. Or when it is a high myopia, it may be seen from 1.75 to 1. So you have to consider these variations in the high myopia and high hyperopic patients. So this is the chart. How do you consider the high myopic patient? How to consider high myopic patients, hyperopic patients? Even the steeper corneas and the flatter corneas also have a different toricity ratio. And this whole thing has been incorporated by the different calculators. So which calculators are incorporating this? These are all the calculators which are considering the effective lens position ratio, but remaining are not. So suppose you are using the Hoya lens and you have a very high myopic patient or you have a very high hyperopic patient, it is not considering effective lens position ratio. So the chances of error is very high. So if you want to use a Hoya lens, then you have to go for the Barrett toric calculator which is available online. So that can be corrected very well. So rather than going for the company's toric power calculator, you should understand which toric calculator has to be considered in which lens. Certain are considering the posterior coronary astigmatism calculations also. So for ideal toric calculator, what we should use? Total coronary astigmatism automatically added as a third factor. That is first thing. Second, variable effective lens position, ELP position calculation should be there in your toric calculator. Centered value has to be added, has to be effective in your toric calculator. And calculator, we are giving the spherical IOL power by itself. So rather than relying on your optical biometry and put in the toric calculator, if your toric calculator is getting that one, that the spherical power is also calculated by the toric calculator, that is considered as a best part. So the Barrett is one of the very good tool for that. The next thing which is coming up is the position of fovea and optic disc tilt factor. Still so many studies are going on. This is one of the study that the optic disc orientation to some extent may indicate the steeper meridian of the cornea. This is another study which is also says that the OCD based, that the coronary astigmatism is considered when the interpreting the optic nerve head and the peripapillary retinal nerve fiber thickness. And lastly, the postoperative tilt factor. We have a newer understanding of the topography of the lens because of this newer tool, that is a OCT based tool which gives the good topography of the lens. Now we have to understand how the lens is positioned inside the eye or how the IOL lens remains the position inside the eye. So this gives an idea about the equatorial plane position. Equatorial plane position gives us the exact what would be the ELP for this patient. And the 2019 Dr. Douglas Kwok and Lee Wang come with this new conclusion of the physiological tilt factor, and most important that it has a significant mirror symmetry between the right eye and the left eye. It also gives a strong correlation between the magnitude and direction between the preoperative crystalline lens and the IOL tilt. So over the period of time we have to understand IOL tilt factor, and that will be incorporated in the toric calculator. One of the toric calculator, Panacea toric calculator, is now giving the tilt factor also. I have told in my first lecture that the Panacea calculator is giving the tilt factor. So newer generation toric calculator will come with the tilt factor calculations. So in summary, instead of SIA value, use the centered value. At present scenario, total corneal power estimation measurement, both are the equivocal. No need to buy the hi-fi equipments for the posterior corneal power. Use the toric calculator which are incorporating all these centered values, PCA estimations, variable toricity ratio, and inbuilt spherical IOL power calculations. And upcoming toric calculators are coming with the tilt factor elements. Thanks for your attention.
Excellent. And the last one is the effective head tilt position. It depends upon your head tilt also.
Depending upon the talk also. So I thank you all the attendees and all the speakers for to be participating in my course. Thank you.